Okay, so we are live today, not just here on Zoom, but also on our Facebook page, which is the Pulmonary Hypertension India. So please note that this session is being recorded. Okay, and we request everyone to kindly keep themselves on mute throughout the event. For technical difficulties, you can just message us on chat. Okay, so I'm Dr. Patil from Mumbai, your moderator for this event. I live with idiopathic pulmonary hypertension, and I'm joined today by my co-host Shalaka Parab, who is also from Mumbai. She lives with pulmonary hypertension secondary to atrial septal defect, which is ASD. And Shalaka and I are both from Pulmonary Hypertension India. We are a patient support and educational platform created exclusively for pulmonary hypertension patients and run exclusively by the PH patients. This is the second part of our series, which is how to stop worrying and start living. The first session is available on the YouTube channel, and it is a must watch for patients interested in quality of life issues in relation to PH. Okay. In today's session, all questions and topics have been specially crowdsourced from patients from different parts of Asia and Middle East. And we thank everyone who has sent their questions. We have received a large number of questions and we only have limited time. So we apologize in advance for not being able to include all of them. We will also exclude questions that have already been addressed in session 1. And please note that nutrition and mental health are also two topics which will not be addressed today because special sessions covering these topics are coming up in following week. Kindly mute yourselves after joining, please. Please watch out for the schedule on our social media accounts. Now, coming back to this important event, I'll start by introducing to you our doctors. Both are young PH specialists with big smiles and bigger hearts. One of them has woken up early on this weekend to talk to us, and the other is taking time out from his Saturday evening here with us today. We are fortunate to have with us once more the very kind-hearted Dr. Sandeep Sahay, MD, FCCP from Houston, Texas. Dr. Sahay is a pulmonologist practicing at Houston Methodist Lung Center, which is one of the largest and oldest PH centers in the world. He has a fellowship in pulmonary and critical care medicine from University of Texas. He was mentored by the great Dr. Danny Frost, a global pioneer in pulmonary vascular conditions. And now, to double the magic, we are also joined by our very popular and endearing Dr. Prashant Bobhate, a pediatric cardiologist practicing at Kokilaben Dhirubhai Ambani Hospital, Mumbai, where he heads the pulmonary hypertension clinic. Dr. Bobhate has a fellowship in pulmonary hypertension and a fetal echocardiogram from Stollery Children's Hospital, Edmonton, Canada. He has also been at the forefront of successful POTS surgeries in India, 19 so far, making it perhaps the largest single center experience in the world. Dr. Bobhate is joining us today from Sindhudurg, a district in Maharashtra, a place he visits every month to see rural patients. Now it's time for me to give the floor to my colleague Shalaka, who will start with the main session. Shalaka, please take over.
Thank you, Dr. Patil. Welcome all fighters, all friends and their family members. Welcome Indians, non-Indians, South Asians, Middle Easterns. We had started this series last time talking about symptoms, and we did discuss symptoms in detail. But we still have a few questions on symptoms and we will take them up now. Dr. Bobhate and Dr. Sahay, the first question is on numbness in extremities. When is it not related to Raynaud's? Raynaud's we know is usually seen in scleroderma. When is it not related to neuropathy? And when is it something that should bother us and we should go to a doctor with? Either one of you can answer this, please.
Dr. Sahay, you want to go ahead?
You're muted. Sir, you're muted.
Sorry, that's the commonest mistake. Sorry. Well, thanks everyone for having me, and thanks Shalaka and Dr. Patil, and thanks Prashant. Numbness is sort of I would say, a little vague symptoms unless it's associated with any connective tissue disease like your um, scleroderma or Raynaud's and all that. Other possible explanation could be poor circulation, and if your systolic blood pressure is lower. Some of the pH drugs, I'm not entirely sure if they are like oral prostacyclin receptor agonists like selexipag can cause some tingling numbness in the extremities. So sometimes it could be drug related, sometimes it could be, and remember one more thing, that it could be a symptom of any associated condition, like if you have some thyroid dysfunction, hypothyroidism, those potentially can cause. So if it is persisting and bothering, then I guess it needs to be further evaluated. If it's a minor issue, it could be related to your hemodynamics and all. And generally, when I see my PH patient, I pay close attention to their blood pressure trends, and that tells me a lot. I mean, many times you have patients saying, "Oh, we're doing great, we're doing everything good," but if their systolic blood pressure always stays around 9500 something, I mean, even if they are saying whatever they're doing, that clearly indicates that uh, their circulatory state, the PVR is certainly to some extent that it is compromising their uh, cardiac output to some limit. So without going into much technical details, but it could be because of an underlying systemic disorder. It could be because of the drug side effects, or it could be because of your worsening pH if it's a new and progressive symptom. So better that you get it evaluated in detail.
Okay. Dr. Bobhate, do you have anything to add to that?
No, I think Dr. Sandeep has covered most of it.
Okay. Our next question is on low blood pressure. Why does it occur and what do we do about it?
Can I take that?
Yes.
Dr.
Yeah,
Sandeep?
go ahead,
Yeah.
Prashant. Yeah, go ahead.
So, yeah. So, thank you, everybody. Thank you, Shalaka. Thank you, Dr. Patil, for the kind introduction. As you know, I am logging in from Sindhurg, so I've kept my video off for internet issues. Anyways, coming to the question of low blood pressure, it is very relevant. And as Dr. Sahay has already said, that we as physicians keep a close watch on the blood pressure of the patient. And a lower pressure in the patient suggests that there is probably the cardiac index and the cardiac output is not as it should be, and further investigation is required, especially with an echocardiogram or an NT-proBNP, to see how the patient is coping up. And if the blood pressures are consistently remaining on the lower side, it might also be an indication that we might have to increase therapy. We have to keep a caution here, because some of the pH medications can also cause hypotension, but that is a completely separate issue altogether, and has to be dealt with by the pH specialist. However, a persistently low blood pressure is not a good sign, and it's a sign that the cardiac index on the lower side and requires further evaluation.
Okay. All right. Dr. Sahay, anything to add there?
No, I think Prashant put it nicely.
Okay.
He's right that you have to be, it's a concerning sign. And if you look at the even data from the risk stratification in PH, looking at the reveal risk, and I don't think in European classification, but reveal risk score, there is a thing about blood pressure. It does mention if your heart rate above 96 and systolic blood pressure below 110 all the time is associated with a poor prognosis. So, like Prashant said, that you have to maybe optimize your pH treatment or see what's going on. And but Prashant made a very good point that it could be side effect from some of the pH medications as well. So you definitely have to consult with your doctor.
Which pH medications cause low blood pressure? If you could name a couple of them.
So some of the drugs which cause reduction in systemic vascular resistance or cause vasodilators, well, all of them are vasodilators, but
Okay.
but some of them are somewhat more than others. Like, for example, uh, I don't know in India, sildenafil, tadalafil, riociguat, these are main ones. And then obviously your IV prostacyclins can always cause.
So pretty much all of them.
Pretty much, because they all are vasodilators, right? The pH
Right.
drugs are vasodilators, so they all can reduce your SVR to cause hypertension.
Okay. My next question is on desaturation. Doctors, have you observed patients desaturating much more early in the morning when they wake up? Because this question is specific to that. What do I do when I go to the washroom in the mornings and my oxygen drops to around 50%?
Prashant, you want me to answer or?
Anyone can
Yeah,
just.
yeah,
Okay.
you can go ahead, Dr. Sahay. Yeah.
Well, so sort of hard to really answer that why it would only happen early in the morning.
Okay. So it's not a common thing to happen in the morning.
No, it is common thing.
Okay.
So
Okay.
that's not what I'm saying.
Okay.
What I'm saying is desaturation is a symptom and or a sign which patient is observing at home. The point I'm trying to make is why patient is noticing only early in the morning. I'm assuming it's probably happening throughout the day. I mean,
Okay.
maybe patient is just checking in the morning. I mean, why it should happen just in the morning when you go to the bathroom? I mean, why it won't happen when later in the day you go to the kitchen? I mean, if you're desaturating, because if you have a systemic disorder, then you should now. In PAH, desaturation, it means multiple different things. For example, I will take just simple, and Prashant knows this much better than I do. I mean, he's pediatric cardiologist, and kids, or even the adult congenital heart disease people with PAH who have shunting, they desaturate like crazy. I mean, they drop their oxygen saturation like anything. So, like for example, patients with very bad pH and ASD, they would desaturate, or patients with some other sort of shunting, they and Prashant can cover that, like what all could. In adult PH patient like scleroderma, if they have ILD associated with pulmonary hypertension, they can desaturate. Patient with liver disorders, they have hepatopulmonary syndrome, they can desaturate. Pure idiopathic patients, technically speaking, unless their disease is very severe, we do not expect them to. If they do not have anything else, then they should not be desaturating unless their disease gets very severe or advanced or long-standing disease. Then you may see some. So many PH patients, and that's one of the challenge getting PH patient transplanted, because in LAS scoring you have a parameter to see if they desaturate and how much oxygen, because once you are on oxygen, your suddenly LAS score goes up. But we struggle with that because many PH patients, even if their RV is failing, you cannot get them higher on the list because they don't use oxygen. So so it could be part of pH, it may not be part of pH, but I don't think that if a patient is desaturating in morning in 50s, that it's just happening in morning. It probably is
Okay.
happening throughout the day. And in the other thing is that if they're noticing at night or something, they should get checked for sleep apnea. And I don't know how many of PH patient needs to get the sleep testing. In my clinic, everyone gets it. Everyone who walks into the door gets a sleep apnea evaluation, or at least an overnight oximetry testing to see uh, to see they're not desaturating while sleeping.
Dr. Bobhate, do you also get sleep app studies done on all patients?
As a part of initial workup, yes, we should get a sleep apnea study for all patients with pulmonary hypertension, especially the ones in which we don't know the cause. In India, sometimes, however, we don't get, if we know the cause, such as if the patient has got Eisenmenger syndrome, then we try to so basically, we try to optimize where we are spending our money. because most of the PH patients would require to be on long-term therapy. If we have a clear-cut cause of PH which we know of, and we feel that the patient is not obese, is active throughout the day, then we don't do the sleep study. However, in patients in which the cause of PH is not known, definitely we should do a sleep apnea study, because that is one of the important causes of PH which can be treated.
Okay. Okay. I'll go to the next section now. This is a very important topic, weight gain and weight loss. And my first question related to that is, how does one know when weight gain?
Shalaka, can I
Yes.
interrupt? I just want
Yes,
to make
please.
one follow-up comment on what
Yes, please.
Prashant said. That he's right. Just that the sleep apnea, if you're noticing a moderate to severe pulmonary hypertension, I mean, mild RV dysfunction, slight PA pressure on echo of around 40-45 in a patient who is big, BMI of 35-40, yeah, we could potentially assume that it could be sleep apnea related. And I totally get Prashant's viewpoint. And this is the difference in the way things are done here versus in India. So here, anyone, even if you see echo PA pressure above 35, gets a right heart cath. So but I agree with Prashant that that in patient you can kind of risk stratify. But if you're noticing moderate to severe RV dysfunction, very unlikely that sleep apnea will be causing moderate to severe,
Okay.
unless you have something like what do you call that, obesity hypoventilation or Pickwickian syndrome or something like that. Um, so if it's a mild, then yes, what Prashant said. But if it's something moderate to severe symptoms you're noticing, then it needs further evaluation.
Okay.
Okay.
So the question on weight loss and weight gain. How does one know when weight gain is related to water retention and it is not actual fat related weight gain?
If you're gaining more than 5 to 6 pounds in a span of 48 hours or 2 days or 3 days, you know that it's fluid. You can't gain that much
Doctor,
weight.
could you convert the pounds to kgs?
Well, I mean, pound, divided by 2.2. Okay. Uh, Maybe like 2
Approximately.
kilos or,
Yeah.
yeah. I mean, the point is, if you're noticing fluctuation, see, trust this. Trust your instincts. You know your body the best. None of the doctors know anyone's body is the best. We just go based on signs, symptoms, which do not have very high sensitivity and specificity, and then we do testing, and we base our decisions on the testing. I mean, if you are feeling worse, if you are feeling short of breath, if you are feeling like I don't feel right, don't underestimate your symptoms. And you're noticing that you're retaining more fluid, you're seeing leg swelling, you are seeing your face is puffy, you are noticing that your weight is fluctuating. Last week I checked, I was whatever 80 kilos and now I am 83 in a span of 5 days. That's some rapid accumulation of your fluid. Or I mean, no one can gain this much of weight unless you're, I don't know what, maybe partying every night and eating a lot of food, I don't know. But you know what I'm saying, that
Yeah.
it's a fluid weight will be much more rapid accumulation. uh, I mean, there is no, unless Prashant has something else to comment on that. I don't know if there is another magic sign to really know the difference.
No, I agree with Dr. Sandeep. Yeah, the weight gain because of fluid is much more rapid as compared to the weight gain because of the fat. A simple way to check it, maybe, and that is how we also check it, is maybe press a little bit just above your ankles. And if you're able to get an indentation there, that is a sign that there is fluid which is accumulated.
Okay.
Just to be sure. But as Dr. Sandeep said, fluid because of weight gain because of fluid is much more rapid as compared to fat.
Okay.
And this simple thing can help you differentiate that. In addition to the to the to the
Yeah.
to the I mean to the time, you know.
Got it. Yeah.
Yeah.
Okay.
I would encourage all PH patients to get in habit of checking their weight every day in morning without clothes, in the what we call as bathroom scale. So check your weight every day. and keep a track of it.
Okay, that's a great tip. Okay. Now, people who actually have probably, gained fat weight here, they end up exercising, strenuously exercising, not realizing that they could be worsening their condition. What would you say to them? And this we've seen mostly in newly diagnosed patients.
Okay, I do not recommend any patient very strenuous weight bearing weightlifting exercises. When you do I mean, yes, I want them to exercise. It should be mild to moderate. There is actually I'll probably share it with you later on. There is a recent document which came out about exercising in PH. Uh, so I do not recommend anyone doing any heavy weightlifting or something like that. We had some patients who were doing like bench presses and all, lifting, 100 pound of weight. And no, I do not, because when you lift suddenly this much of weight, it increases your central aortic pressure. It causes more turbulent flow through your already narrowed pulmonary circulation. And then if you do not, your because of the disease you don't have a capacitance, so you may limit your cardiac output. If not, then people believe, again, I don't think this is proven, but we do believe that more turbulent flow causes more worsening in terms of or triggers the pulmonary vasculature remodeling, because it's not a normal pulmonary um, arteries. So no, I do not recommend anyone doing heavy lifting, heavy exercise, mild to moderate exercise, walking. You could do, and if you want to do weights, light weights, maybe one arm at a time, like those 5 pounds weights, what do you call, dumbbells or something. That's what I recommend.
What about cardio? Because walking is also, I mean, recently we heard of patients walking strenuously for 1 or 2 hours trying to lose weight. I think even that would be
Okay, if we are focusing
detrimental,
on
right?
if we're focusing on weight loss, let me tell you
Yeah,
one thing very clearly, that weight loss is a function of your diet also.
yeah, exactly. Yeah.
So you can just kill yourself by exercising and running a mile and then eating the Indian fatty diet, So what I'm trying to highlight is that if you really want to lose a weight, you just cannot be fixated. I want patients to be active. I don't want them to be just sitting at home and not doing anything. That's why we treat, because the idea is that they go out and do their day-to-day activities, right? But if you really want to lose weight, it's not only about doing the exercise. It is a function of you, what you're eating, what you're putting in your mouth. If you are, I mean, I know Indian diet very well, which is not very healthy. And if you're eating every day, rotis and parathas and all that, it's not going to help you for sure. You will not lose weight. Uh, and then all these sweets, oh my God, they're so tasty, but still, you're not going to lose weight. I'm being honest. I mean,
Yeah, of course.
it's winter time. Everyone eats like gajar ka halwa. You're not gonna lose weight. Uh, so you have to look into what you're putting in your mouth. You have to do your calorie count, like how much, low carb diet, all these things which have been proven to show benefit. And problem is not with the low. I mean, this is a whole new chapter about losing weight, because low carb diet then it becomes more addicting. Sugar becomes addicting. Then in India, you drink tea at least 5 times a day with sugar and with milk in it, and those are calories. I mean, everything counts, right? So you don't kill yourself just running 2 hours, and then you're saying that I ran 2 hours and I'm still not losing weight, because you're not paying attention to your diet then. Okay, so keep yourself active. 30 minutes exercise, 30 minutes walking per day is absolutely fine. But don't kill yourself and by doing some extreme measures. And then obviously discuss with smart physicians. You have Prashant there locally, who has deep interest in pulmonary vascular diseases, and check with doctors like him. Um,
Dr. Prashant, you have anything to say on this?
No, I completely agree with whatever Dr. Sandeep is saying, and of course, what we advise the patient is you are your own guide, and
Yeah.
never overdo one particular thing, because overdoing one particular thing is going to be harmful, and you always have to have a balance between what you're eating and what you're exercising, because that is the one which is going to give you the maximum benefit.
Okay, all right. One last question on the same topic is, you've already mentioned about checking your weight every day in the morning, and two, checking for edema above your ankle. Is there anything else we need to do to check for edema signs and symptoms?
I
Is
think
anything
what,
else?
no, I mean,
yeah,
Prashant, go ahead.
sorry,
I
yeah,
can't think of anything.
yeah, I also agree. I mean, these are the two basic things
Okay.
which we can do.
Okay, all right. Next topic is thyroid. We see thyroid very commonly in women. We see pH very commonly in women. Is there a connection here?
See, some thyroid diseases, both hypo as well as hyperthyroidism, are known to be associated with pulmonary hypertension. And there is a higher incidence of thyroid disease in pulmonary hypertension. The exact mechanism how hypo or hyperthyroidism can cause pulmonary hypertension is not known. One
Okay.
of the theories is maybe both of them are autoimmune in nature. So that could be one of the reasons why there is an increased incidence of both of both occurring together.
Okay.
Uh, However, again, if you have hyperthyroidism, the pH is completely different. It's usually associated with a high cardiac output, and it's not usually very severe.
Okay. Okay, that's good to know. Well, our next question, Dr. Prashant, this is specifically to you. Why are ASDs, VSDs, and PDAs not closed in adults?
Uh, I think that question is so. It is so whenever we have it's a very difficult question to answer. It's not that we do not close ASDs,
Okay.
VSDs, and PDAs in adults.
This
We
is the context of
definitely,
people with pH, obviously. I mean,
yeah,
I'm guessing most of
yeah,
them do have pH as well.
right.
Yeah.
So these shunts are actually helping them,
Hmm.
even in a child. If say a child is 7 years or 8 years of age, or anyone who is in fact maybe more than 2 years of age, having a shunt at the atrial level or the ventricular level or the ductus arteriosus level is actually helping them, because once if when the patient has got increase in the cardiac output, these shunts actually act as decompressions. When there is increase in the pulmonary vascular resistance, these shunts will decompress. It will maintain the cardiac output at the cost of desaturation, of course. But
Okay.
in a patient with pulmonary hypertension, these shunts or these holes are actually a blessing in disguise.
Okay. Okay. Got it.
I just have a follow-up comment on
Yes.
what Prashant is absolutely right, what he said. Uh, you need to understand that patients who have these shunts like ASD, VSD, or PDA, they develop pulmonary hypertension over a period of time. Okay, it doesn't happen when they're born or they have ASD and they have PH on the same day. No, it happens over a period of time because of the impact of that shunt and increase in your pulmonary blood volume, pulmonary flow, and then at some point in time, the shunt, which is initially left to right, means your left-sided circulation, which is a higher pressure system, goes to the right side, and then when the pressure on the right side starts to go up, when you start to develop pulmonary hypertension, then it becomes right to left, which is what Prashant is alluding to, saying
Hmm.
that it's sort of like a decompression. Now, in this whole spectrum, depends on when you present to the doctor.
Hmm.
I mean, if someone is like, I'm sure Prashant is expert in this, that if he has a young kid who comes with just ASD with left to right shunt, and I'm sure on daily basis he probably recommends closing, or maybe he does it, a bunch of kids, right? But then when they present into adult and the flow has reversed to right and left, and there is, higher PA pressure, then you cannot close, because the moment you close, it's like like what he's saying, it sort of decompresses, right? So if you close it, you're suddenly going to increase the pressure on the right side of the heart. You will precipitate the right heart failure, and then you will end up having a bad outcome. So so you need to understand that. Don't feel this, that my doctor is not, oh, I saw that other patient who got the shunt, fixed, and now my shunt no one does, or no one is fixing my ASD. It depends on where you fall into that spectrum and where you are. And now, even in the adults, I mean, I had few adults who we got, the shunt fixed and all, but you have to do a careful assessment. We did their cath, we did their exercise cath, then looked at their hemodynamics, what their PVR is, and then we decided, okay, hey, we should probably go ahead and close the ASD in an adult. Like I recently did on a 40-year-old woman, just because her PA pressures were normal, she didn't have pulmonary hypertension, the flow was left to right, and it's not reversing. So yeah, go ahead and do that way. But again, if you have developed pulmonary hypertension, then it's very challenging for, like Prashant said, that it actually helps in those patients if you have severe pulmonary hypertension.
Okay, got it. Next category is very, very important, tests. And it's important because different tests are being prescribed across the country, even in different countries in South Asia. Other than the echo, there are many others which are not being prescribed at all. So which are the most relevant tests for pH? And I mean, besides the echo, of course, right at the beginning of the diagnosis, what do doctors have to insist on?
From the adult, pH is remember one thing, pH is a complex disease, and it has a equally complex management. So testing is very or extremely important in PAH. So I know we all live in a different healthcare system. So there are implications on the cost, financial implications on getting the testing done, time, quality of testing. There are a lot of issues which come into play. But unfortunately, PH is a disease. As I always say, it's not like asthma, it's not like common cold that which will go away. It is a disease which will stay, it will progress, and it will probably decide your rest of the life. So one has to take the priority that we get all the testing done correctly at the right place and relevant place. I mean, it's an exhaustive list of the testing. I mean, the screening tool is echo, which is minimum, and then echo is the basic minimum which is used in follow-ups of these patients every 3 to 6 months. In my clinic, patients generally follow up every 3 months, and we do 3 to 4 months. Unless someone is really stable, then maybe 6 months, but generally 3 to 4 months, and they get echo, lab work, which includes their liver kidney panel, BNP, CBC, and hemoglobin, and a walk test. This is the basic minimum which I do in almost every PH patient every 3 to 4 months. At the time of diagnosis, they go into an exhaustive list of evaluation, which starts from their CAT scan of lungs, echo, right heart cath, depending on if they're idiopathic, they are drug and toxin related PH, or heritable, where I know about the genetic mutations. Then we do the vasoreactivity testing. If they are connective tissue disease or some portopulmonary or some other thing, then we do not do the vasoreactivity testing. This is as per the current guidelines. And then we do right heart cath with the full panel and like different hemodynamic set measurements and that. We do a perfusion scan, VQ scan, to make sure it's not CTEPH. Okay. And then and then obviously you do lung function test, you do walk test to assess if they need oxygen or not, and what is their baseline walk distance, how much distance they have walked in 6 minutes, because once you start treatment, that will be your reference point of improvement, not improvement. That's sort of surrogate for their functional capacity. Uh, one of the testing which I don't routinely do, but there is more data now getting accumulated is cardiopulmonary exercise testing. I'm not going to go into that detail. It's a complex test, complex interpretation, and not every center, even in the United States, not every center is equipped to do that. Okay. But the names which I mentioned, like echo, right heart cath, lung function, walk test, some blood work, CT scan, these are the basic tests which one should. And depending on, let's say, initial thing shows you have liver cirrhosis and you have portopulmonary hypertension, then you will need a liver evaluation also.
Correct.
If your basic evaluation shows you have scleroderma, then you may need some testing relevant to scleroderma also, right? So some blood testing or whatever else. So that's how we take approach in PH, initial evaluation and then follow up. Once you are stable on the drugs, then you just follow up in clinic, and then we do, like I mentioned, the echo, walk test, and blood work. That's the basic minimum.
How often do
So
you all do RHCs, doctor? Right heart caths, how often do you all do
so
them?
now if I have a new patient diagnosed, then I look at the response to the treatment, and I do, if they are not at goal, which means in the low risk, then at 3 months I do a follow-up right heart cath
Okay.
to assess if I need to escalate therapy. We start on an upfront combination treatment. At 3 months, 3 to 4 months, do another heart cath, see where we stand. And then after that, there is no consensus when should be done. Then it depends on the symptoms, and the treatment response. If, let's say, at 1 year patient is still struggling and I have already started patient on 3 different drugs, now I'm contemplating putting the patient on IV prostacyclin, and before that I would do a heart cath. Or patient is already on IV prostacyclin and all other oral drugs and still not responding or something, after 3 to 6 months of titration of drug, then I would proceed with a heart cath. Or there was a very stable, very functional young patient, or even older. I mean, I'm not discriminating based on age, but I mean to say any patient who was very functional and doing really well, and then all of a sudden I noticed that, oh, what happened? Like echo looks bad, or walk distance dropped, or patient started complaining symptoms, then yes, you need a right heart cath. Every time I add a new therapy, I do a right heart cath. Right heart cath is the most gold standard testing which would provide you the most relevant information. Okay, I
Okay.
mean, as you know, my mentor published a paper 7 years ago in JAMA. You can read it, that many patients get medications prescribed wrongly, uh, just because based on the echo diagnosis. I mean, so you must have a right heart cath,
Okay.
and I do my own heart cath. So I know my patients, like what happened in the heart cath, what their last numbers were, what their follow up numbers were. So I know what I'm doing.
Okay.
So I mean, in some circumstances, I ask my cardiology colleagues to do it, because if they have a left heart disease concern, especially in older population where you have mitral valve or some other issues, then obviously I have some of my cardiology colleagues do it.
Okay. I would like Dr. Prashant to weigh in here on the Indian experience of right heart caths. Doctor, how often, when do you all do it? And if you vary in the number of tests done for diagnosis.
So, yeah, I think it is very well covered by Dr. Sandeep. I would like to add one more test to the armory at the time of diagnosis. Of course, in addition to all that Dr. Sandeep has said, we also should do an ultrasound abdomen with portal venous Doppler. We have found out that there are certain patients who are labeled as idiopathic pulmonary hypertension, and when we do this test, we have found them to have portocaval malformations, what are also called as Abernethy malformations, which can be both extra as well as intrahepatic. And once these shunts are closed at a proper time, there might be reversal in, or there might be improvement in the pulmonary artery pressures. Uh, right heart cath is a very tricky question, especially in India, and there are various reasons for it. Uh, One reason, of course, is by the time the patient is referred to us, uh, he's already on medications, because there is no restriction into who prescribes this medications and based on what. And as Dr. Dr. Sandeep said, there is a lot of patients who are either overprescribed or underprescribed medications. When we want to correct that, we definitely do a right heart cath. Uh, I would I would differ in the number of right heart caths which we do, because once we have established the diagnosis, if the patient is usually worsening because of the increase in the pulmonary vascular disease, uh, then so follow-up right heart caths is what we usually don't do in India very frequently, unless you're listing for a transplant or something like that.
Hmm.
Uh, Baseline right heart cath is completely recommended, but hardly ever done. The reason being, most of the times the medication is started on echocardiogram, and the practice is such that it's very difficult to convince the patient, very difficult to convince the caregiver, very difficult to convince the referring physician. Uh,
Hmm.
and as I said, most of the times patient is already on medication by the time the patient comes us. But if I find a patient who is not on medications, any medications, definitely we would recommend a right heart cath before we start anything else.
Okay, got it. Can you doctors talk about the NT-proBNP test and its importance?
So, as Dr. Sandeep said, what we look at in follow-up is what we're looking at. In India, we basically look at four things. One is what is the symptoms of the child, of the patient, what is the echocardiographic findings, the NT-proBNP, and the 6-minute walk test. The reason being, we want to risk stratify the patient and see if the patient is responding to therapy or not. And we need to understand that we need to get the patient to the low risk category and keep the patient in the low risk category as long as possible. And we don't want the patient to go into high risk category for us to escalate therapy, because then it is quite late. So for managing medications as well as risk stratification, I would do NT-proBNP definitely at baseline. And again, it depends upon patient to patient, but at least every 6 months we need to do it.
Okay, just coming back to the test before I go into a right heart failure, can you all teach us how to do a...
I have a couple of comments. I think I
Yes.
didn't specify when Prashant was mentioning uh, in the pediatric world, doing the right heart cath is I was referring totally to the adult world, and I didn't realize Prashant is a pediatric cardiologist. So, it's a totally different world, right? So I agree with Prashant. Even in the United States, in the pediatric, when I get transition patients from Texas Children, um, they generally don't do much heart caths because in pediatric world is I think for multiple reasons. Obviously, in adults, if you look at doing the right heart cath, the current guidelines don't even recommend doing sedation. You do it just under local anesthesia. In pediatric population, you need to probably do a general anesthesia. Now, general anesthesia is anyway not friendly with PAH hemodynamics. So that complicates things there, right? Because kids won't be easily, I mean, if you have a 6-year-old kid, you can't explain that child, hey, stay still, we're going to poke your neck and all that. And obviously the parents' emotions and all that kind of things play a lot of. So it's somewhat more challenging in the pediatric world for sure, definitely. But what I was referring to was the adult world. That adult world is different than the pediatric world. As a follow-up on the NT-proBNP, there is clearly enough data in saying that in circulating higher NT-proBNP is associated with higher mortality. There is actually a recent paper which just came out, and that's why it's part of the all scoring methods. And like Prashant mentioned about risk scoring method. I don't know if you guys are aware of any risk scoring method like low risk, high risk, or intermediate risk in PH, and how to 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 follow them up every time you are seeing a patient in clinic. I can pull it up on a table and just show
I'm
you
sure
what the
Dr.
risk
Bobhate
is.
must already be following that, right, Doctor?
Yeah. One more thing, Sandeep. So actually, I see adult PH
Yeah,
patients
I
as
was just going
well.
to
Oh,
say
okay.
that.
The
Okay.
reason
Sorry, I
is
didn't know that.
Yeah, yeah.
Okay.
the reason is not many of our adult cardiologists want to see PH patients for various reasons, uh, but it is in India. It's really challenging to get a patient to the cath table. Believe me, it's very challenging.
There are also socioeconomic factors in prescribing of RHC, I think, for many.
Yes, it is. And see, in our institution, we have capped it as 25,000, which I feel it is still on the higher side for a right heart cath, but that is what a bare minimum is. See, because the problem is
Yeah.
the thermodilution catheter by itself is going to cost us around 9,000 rupees, in India. So, and because of that, we have capped it as 25. Then you take the cath lab slot, and PH cats tend to be a little longer than the normal coronary angiogram. They get finished in 15 minutes, and here we are testing various medications. It takes us close to an hour, 45 minutes to an hour, and our adult cardiology colleagues start getting palpitations when we are doing the right heart cath. So that is why we have to cap it a little higher cost, and it's challenging to get the patient to the cath table in India.
And challenging to get the cardiologist to do it too, unless you're a PH center or you have a doctor focused on PH. That's been an
Yeah.
observation with patients from
So
across the country right now.
yeah. So whenever we go for this CMEs with our doctor colleagues, I have a slide and I say that like your antibiotic is not your fever is not a sign of antibiotic deficiencies. Similarly, having pulmonary hypertension is not a sign of sildenafil deficiency. Just don't see pulmonary hypertension on echocardiogram and start medications. There is a lot more to it, and we need to
Yeah.
investigate.
And
Okay.
he's Prashant. I totally agree with that statement, actually. But here in this group, I see around 50 patients sitting here. I guess if one lesson they want to learn from here, that they should, if they have not discussed or never had a heart cath, whoever they are seeing or treating or doctor, whoever they're talking to, they should probably bring this up in the discussion if you have never had any. And uh, because the purpose of doing these meetings is to educate the patient, and I guess that's what we're trying to emphasize, that that's the most important tool. And in the beginning also, I did mention that we all live in a different healthcare system, and hands down, cost plays the biggest role. Trust me, here also,
Yeah.
the cost plays if the insurance denies anyone's right heart cath, there is no way that I can do a right heart cath. No way. Okay. So uh, Prashant is absolutely right. If it's expensive, they're cost prohibitive, I would strongly urge at least do the baseline, a diagnostic heart cath, so that your diagnosis is correctly done. And I would suggest to be done at an expert center like Prashant's place. I mean, obviously, Prashant, I don't want him to be bombarded tomorrow morning with phone calls like 1,000 new patients, right? So, but I mean to say, people like motivated, energetic people like Prashant, and um, uh, because it's not only about doing the testing. If you're investing 25,000, I didn't realize 25,000 is a lot of money considering India. And if you're doing a right heart cath and you're spending $25,000, I mean, sorry, not dollars, rupees, then um, obviously you want to have a very good information from it. I mean, I personally see heart caths done like many times on patients, and the information on them is like pretty much like not relevant. I don't know what those numbers mean, what that means. So the zeroing errors and bunch of things. So you have to. So it's very important that testing, not only it's being done, but it is done correctly, and it is a quality testing and the quality interpretation of those findings, because that's also important. PH, as I said, again, it's a complex disease with complex management. Like Prashant said, there is a lot more to it than just sildenafil deficiency, right? That's what he said. So, which is absolutely right, because there is, even if you do hemodynamics, you may find a wedge pressure high, but then you look at the PA pressure is out of proportion. You may still err towards treating the patient. You may take that. So these things need some closer monitoring, and especially in adult people, because they may have hypertension, they may have diabetes, they're obese. There are a lot of other things which affect hemodynamics. So it's important that you get it done at a right place, and the interpretation of those findings are very important.
Okay. All right. Let's move to a very important topic, right heart failure. What are the early signs of right heart failure, things that we should notice at home and on our own? And when do we go report them to the doctor?
Well, in my opinion, like we discussed some of the things earlier, if you are absolutely stable person, like, I mean, you're diagnosed with PH, you're living your life, you're taking your medication, nothing else is going on, and all of a sudden you're noticing, oh, I feel a little short of breath doing something. I'm finding my day-to-day activities a little bit challenging. Walking upstairs, I'm feeling the shortness of breath. I'm seeing a new leg edema. I'm seeing a new leg swelling. Or lightheadedness, dizziness, passing out. One of the things which I generally ask patients, I don't know if you know about tying your shoelace sign, that you bend down to tie your shoelace, and if you start feeling dizzy, that basically indicates your elevated filling pressure. So if all these are new signs, symptoms which you are experiencing, then I guess it's time to go and get checked out, because this could be early sign of RV dysfunction. So passing out, if you pass out, don't assume that it is, oh, I just passed out, maybe my blood sugar was low. No, it is not. If you are PAH and if you pass out, that's scary sign. You need to go and talk to your doctors. Okay, and lightheadedness, dizziness, those kind of things. Prashant, feel free to add in if I missed something.
Yeah. Pretty much Dr. Sandeep has covered everything, and apart from that, he had given us a very important tip to check our weight every day. And any sudden increase of weight in the last 2 or 3 days or a week's time, if you have put on more than 2 kilos or 3 kilos of weight, just visit your doctor.
Okay. Is right heart failure reversible, doctors?
Go ahead, Prashant.
No, yeah. So it depends upon what the cause of right heart failure is, and if it is a progressive pulmonary hypertension, then we need to optimize medications. It is reversible to a particular extent. If we optimize medications, then patients might come out of right heart failure.
So we lost Dr. Prashant.
If the patient has got an intercurrent infection, and if you, hello,
Yeah, we
hello,
have you
hello,
now. We have you now.
hello, can you hear me?
Yes, we can.
Patient has got a right heart failure because of an intercurrent infection. Then that, if you treat the intercurrent infection, then the right heart failure is reversible. If you have got certain correctable disease, sometimes patients develop anemia while on medications. If you correct those thyroid deficiencies, so if sometimes patients develop hypertension over the period of time. So you try to correct the correctable diseases, the correctable causes, then right heart failure in a way, in those conditions, may be reversible.
Okay. All right. And
and one follow-up comment on this, Prashant rightly said, the only thing in PH and right heart failure which worries me is if you have a new diagnosis of PH and patient presents to you in right heart failure, at the time of diagnosis, like new patient, you were rounding in hospital and you find this new patient with frank RV failure. I mean, obviously it's bad, but it's not, I don't worry that much on that patient, because that patient is treatment naive. Right now, there is a scope for me to put him on 3 drugs and start on IV prostacyclin and blah, 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 and then do everything and then see the response, because there is a scope of, like Prashant said, optimizing the treatment. This patient is treatment naive, not on any drugs right now. But if someone is already on 3 drugs and I'm seeing for 1 year, 2 year, 3 years, and then the patient has right heart failure, that is concerning to me, because then I can optimize as much, but if your RV dysfunction is pretty severe, there is not much room to improve it further. Then probably it's time to call transplant. So that's just two different interpretation of the right heart failure. And then obviously Prashant, what he said is absolutely right. If there is other explainable causes like infection, etc., you can fix those things. And thyroid dysfunction is important because prostacyclins can sometimes mimic presentation like right heart failure. We published about it a year ago or so. The prostacyclin drugs can cause hyperthyroid states. So you have to be careful if patients are on IV prostacyclin to check their thyroid function.
Okay. All right. This is specific to women. Sometimes the frequency of menstruation in women with pulmonary hypertension increases. And could there be a pH-related right heart failure cause to it?
Well, you know that the pH is a disease of women. So everything is about women here. It's like 4:1. Reveal registry showed us initially we used to, NIH told us it's 2:1 ratio, but now we know it's 4:1 and maybe even more. So there is a whole investigation into the estrogen and all that in women. There is actually just published, I have not read this paper, I didn't get time, about the menstrual cycle variation in pH in Annals of ATS, if anyone wants to read it. But I'm not aware of any data about increased or infrequent menstrual bleeding associated with pH. But let's put it this way, that is a symptom which is generally like menorrhagia. So many pH patients are on blood thinner, right? So that can cause heavy menstrual bleeding. Iron deficiency in India is rampant. So because majority of people are on vegetarian diets and maybe parasitic infections or something like that. So iron deficiency can exacerbate your pH. Plus some of the medications like embricentin and macitentan can cause anemia. I don't know if bosentan has been documented, but I don't know which one is available in India. But what I'm trying to say is that it's not directly related to pH, but if you are noticing a trend, I think, and thyroid dysfunction can cause abnormal menstrual bleeding. So you probably want to get that checked out. I don't think there is any data or I am aware of which has direct relationship between pH and abnormal menstrual bleeding. The only thing I know is that, what is that?
More frequent menstruation is what has been observed.
Yeah, I mean, it could be other factors, like could be local factors. You have fibroid uterus or something.
PCOD or something.
Now, yeah, or PCOD or something else. You're obese, you develop PCOD. One thing I would like to tell here to all PH women of childbearing age group that contraception is very important. I mean, it's sad to say, but as of today, we do not recommend getting pregnant if you have PAH. It's against the current medical advice is not to get pregnant. The second thing which generally OBGYN doctors prescribe are the birth control pills. Be very careful about them. I generally pick up a phone and talk to the OBGYN I do not like them to be on estrogen-based birth control pill. I generally recommend progesterone-based or very low. I mean, here there are different salts, but I don't know what are available in. So something like progesterone-based drug, because estrogen, um, I don't know, but there is some data about estrogen playing a role in PAH, making it worse. So we generally tend to avoid, not only for that reason, but also sometimes these birth control pills are thrombogenic, so they can increase the propensity to form clots. So which is obviously not very well tolerated by PH patients if they develop any clot in the lung or legs and all. So I generally recommend women going with some alternative contraception, like intrauterine devices, but then obviously you have to make sure that you don't get infected and all that. And then maybe partner having, maybe condoms or maybe some vasectomy or something like that. Um, in some younger women where we feel there is a high risk, we generally recommend dual contraception methods so that to minimize the chance of getting pregnant. But it's an individualized approach. There is nothing, uh, standard guidelines. The
Okay.
main thing is I generally personally avoid any estrogen-based drugs.
Okay. Dr. Bobhate, have you seen women patients coming up with frequent menstruation issues?
Yes, we do see them quite often. But as Dr. Sandeep said, there are usually secondary causes of it, right?
Okay.
Some might have endometriosis or some might have fibroid.
Okay.
So we need to investigate them.
Okay. All right. Let's quickly go to medications. This is especially to Dr. Prashant. Why are some patients still on bosentan when macitentan, ambrisentan are already launched in the country? Is there a clinical, scientific reason for that? Doctor, you're breaking. Just give it a moment.
Well, see, since
Yeah.
we keep on coming in the market, we need to more to the previous medication which the patient. Yeah, is it better now?
Yeah. Could you please repeat
Hello?
yourself, the last sentence? Yeah.
Yeah. See, whenever new medications keep on coming in the market, initially we had bosentan, then we had ambrisentan, and now we have macitentan. So the reason for changing from one medication to another in the same group would be if my patient is not doing well on the previous medication. If my patient is doing well on bosentan and she is tolerating well on bosentan, I find no reason to change her over to macitentan or even ambrisentan for that matter. See, bosentan has found, I agree that bosentan has found to have liver dysfunctions, and you need to, according to the guidelines, you need to do your LFT every month. But somehow in India, the incidence of liver dysfunction with bosentan is very, very less. So in my personal experience, I only had to change from bosentan to ambrisentan only in 2 patients for derangement of the liver function test.
Okay.
Remaining all patients who were on bosentan continue to be on bosentan. Of course, if you have a treatment naive patient who is not on any previous medication or he's not on endothelin receptor antagonist, then you add him or her on the latest medication which is available. So we'll
Okay.
add him on macitentan.
Okay, but so there is a discrepancy because we've seen many patients from outside of the metros who the newly diagnosed patients are not given macitentan. They started off on bosentan for some reason, which is
The reason for that is availability.
Okay, that's possible. Yes.
Yeah.
Okay. Something on prostacyclins, and actually, I would again ask Dr. Prashant to weigh in here. When do you put Indian patients on prostacyclins? I know the usage is going up. The drugs are likely to come into India very soon. But at what time do you decide to put them on prostacyclins?
So, as we discussed previously, in PH patients, we need to risk stratify into mild, intermediate, and severe risk and high risk patients. So, if my patient is on maximum oral medications, that is both phosphodiesterone, like sildenafil tadalafil group and the ambrisentan and bosentan group, and the patient is not doing well in any of the 4 parameters, not doing well clinically, not doing well echocardiographically, 6-minute walk test drops, or there is increase in anti-proBNP, I would be recommending them to start on prostacyclin analogs.
Okay. And do you find treprostinil being preferred over iloprost? Because that's a question that came in.
See, treprostinil is definitely by far, subcutaneous treprostinil is by far the best medication according to whatever limited experience I have in managing patients in the prostacyclin group. The problem we have in India is, one is availability and the second is cost. So taking treprostinil every month would cost us close to 2 lakhs to 2.5 lakhs per month.
Hmm.
Iloprost is the one which is much cheaper. It's around 30 to 35,000, and I have recently published a case series of 16 patients on Iloprost, and 70% of them do well. And it depends upon at what time you start the prostacyclin. You wait too long for the right heart to fail and then start prostacyclin, then it doesn't work. You
Hmm.
have to start it early in the disease process.
Hmm.
The other issue with iloprost is it has to be inhaled and it has to be taken 6 to 9 times daily. That is another problem with iloprost.
Hmm. Okay. Okay. So there's a compliance issue as well.
Yes.
Okay. All right. Can one of you explain the difference between IVs and subcutaneous infusions?
Sure. Prashant, you want to do, or you want me to take that?
A quick one.
So quick, yeah.
Yeah.
So what IV means intravenous. So we have these veins in the body in which it will go intravenous. For the prostacyclin part of it, we'll have to put a port or we'll have to put a peripheral inserted central line and give it through the IV pathway. Subcutaneous means in the fat. So it will go in the abdomen or in the thigh.
Okay. All right. And which one is easier to administer at home? Obviously, the
Subcutaneous, of course.
sub-Q one.
Subcutaneous, yeah.
Okay. All right. Let's
Yeah,
go. Yeah.
our center don't do sub-Q actually. I mean, Prashant is right. It's very convenient for the patients. And for some reason, there is a very interesting anecdote in sub-Q remodeling that pediatric patients tolerate it much better than the adult patients. I don't know if that's something to do with the pain receptors or something. Uh, Traditionally, our center has always used IV prostacyclin, epoprostenol, Flolan, and now Vilitri. Um, we have less percentage of patients on remodeling, just unless there is some insurance region or some other logistic issues. Uh, but uh, what we have robust experience in intravenous pumps. We don't do subQ too much just because, and that's actually variable, not from Prashant, but even in the US centers, I don't think any other center does that much IV as we do. And I guess the reason is that we don't like, I personally don't prescribe any pain medications. And with subQ, the site pain becomes so much of an issue that you have to, either you're prescribing some pain medication they can tolerate and all. I mean, that's probably one of the areas where being little fatty helps, because if you have little subcutaneous fat, then you can have less pain. If you're very muscular and athletic, it causes more pain. So I guess that's one of the reasons that I don't want to, because then you have to, in the United States with pain, you have all these narcotic based drugs, and
Yeah.
you want your patients to be away from them. So our center traditionally, historically, and even now, we don't do too much of sub-Q. So our experience on sub-Q is remodeling, but I don't think there is any head-to-head efficacy data. I mean, it's pretty much considered parenteral in both forms, and if you're failing that, then obviously the next step is transplant if you're on that.
Okay.
And iloprost, obviously Prashant has more experience. In my lifetime, I've never even used that. I probably had one patient on iloprost, inhaled iloprost, just because it came in the US maybe 15 years ago, was used, but then soon after that, inhaled treprostinil came, which had a relatively longer half-life, and that's my to-go inhaled drug. And now we just completed 2 trials with just like an inhaler form. So that's with the FDA for approval. So hopefully this year we will just have like a dry powder inhaler, just like asthma inhalers. Um, so hopefully that will be, but it still has to be taken 4 times a day.
Okay. Okay. A very quick question on calcium channel blockers and also warfarin. Which specific pH patients are they both indicated for?
So data about calcium channel blocker is only for the vasoreactive patients.
Okay.
That means, like Prashant mentioned, when we do the initial right heart cath, the baseline, and then you do the vasoreactivity testing. There are certain criteria, and if they are positive, then you can just treat them with calcium channel blocker. And the advantage of doing the vasoreactivity testing is that uh, basically it's a low risk group. These people generally do well, and they may just stay on the calcium channel blockers. You may not need these other expensive pH therapies. They have a better survival than others. So that's why it's important to identify that subgroup. Regarding warfarin, it's sort of fallen out of favor. I would say it's not. I mean, there is no so many years ago, 15, 20 years ago, we used to use anticoagulation in all idiopathic PH patients or heritable PH patients. And but then at that time, we used to think it's maybe the small clots, maybe thrombus or something. That's why people develop. Now we know it's the endothelial and smooth muscle dysfunction, and it's totally unrelated to any clots that people develop PH. It's totally we still don't know why this happened, but we believe it's BMPR2 down regulation that triggers the vasoproliferation. The bottom line is that the data about anticoagulation, I'm talking about only idiopathic and heritable PH patients, that it's not, I would not say yes or no, it's just not clear.
Okay.
So for me, if there is another reason for patient to be on anticoagulation, like for example, they have a history of clot or they have something else going on, maybe AFib or something, that's why they need it, then yes, they stay on that. If I have a new patient diagnosed with idiopathic PH, I don't start anticoagulation. If I have, unless there is some other reason, right, like any other clots and all. If they're already on anticoagulation, not causing any problem, I just leave them alone. But if there is a concern for like heavy menstrual bleeding in a woman or someone bled or nosebleeds, etc., I stop it. Um, uh, that's my take on anticoagulation.
Okay.
But obviously, if you have other reasons like scleroderma and all, where there is clear evidence that anticoagulation is more detrimental with the risk of bleeding, so I don't give anticoagulation in that.
Okay. Dr. Bobhate, you want to add something to that, or can I go to the next question?
No, I think our experience is even similar to what Dr. Sandeep has said, So we can go to the next question.
Okay. This is on lifestyle in general, the next category. And it's a very simple question. What is your best disease management advice to newly diagnosed patients? What can they do?
Live
Things
your
that,
life,
that
not your
are in their
disease.
own control, beyond the medications and everything. What should they do or not do?
I say live your
One
life,
thing I tell
not your
them not
disease.
to do for sure is don't go to Google.
Yeah,
Yeah,
good advice.
and don't go to Google.
Yeah. Dr. Sahay, you were
It's
saying something?
always it's
Yeah, sorry, go
always
ahead.
better. It's always better to get your information from verified sources. Uh, Pulmonary Hypertension Association has got a very good website and it's
Yes,
very informative. So it's better to get it from those sites rather than randomly on Google.
correct. Yes.
Yes.
What else, Dr. Sahay, from you?
Well, I was just saying that live your life, not your disease. Um, just live your life. I mean, don't. This is something which is beyond your control why you had it. What is in your control is go and find the right doctor and get yourself treated rightly and do the right things and just follow that. Culturally, I mean, I'm from India, so I know it very well. I lived my most of the life there. So I know culturally we have tendency to worry a lot and think a lot. So I don't think that that's going to help anything. Your job is you got a symptom, you went to the doctor, you be a smart patient.
Yeah.
Don't be a stupid patient or dumb patient. Be a smart patient. ask right questions, and that's why these kind of forums are basically to educate you so that you can understand when things are not right or wrong with you yourself, and then report it to your doctor. And you should be blessed to have physicians like Prashant there who are motivated and who have deep interest. He's an academic guy. I'm very impressed with his work. And and then contact physicians like Prashant. It's a beginning, and I'm sure soon we will have more physicians interested in the disease. It's a rare disease. Even in the United States, there are challenges. It's not that here. That's why the whole concept of having a comprehensive care center, and you know that not every city, even in the United States, has a big PH center. So it's just a um, ongoing thing that we just have to keep working. And um, that's just a nutshell. That just don't worry too much, don't think too much. What's going to happen to my family? What's going to happen to your kid? Because you can't control that. That's something totally beyond. What you can control is getting yourself treated, going to the doctor, getting the test done. That's it. Beyond that, you just can't control anything else. That's how you're going to behave. It's dependent on the type of disease you have, you're being treated rightly, going to the right doctors. Those are the things which you can control. So worrying is not going to help. As far as Google, Prashant very rightly pointed out about this Google thing. But I actually honestly don't tell anything to my patient. They want to go to Google because I can't control anyone's home computer and their fingers. I'm sure if I tell them, they'll definitely go to Google. So but Prashant said it rightly, that go to the right places, like, the Pulmonary Hypertension Association pages where you get the right information. That's important. And forums like this, they provide you, tend to provide you the correct information. But I don't ask anyone to, because I know that it's just a human nature, right? If I get a rash on my toe, the first thing I'm going to do, which I can understand, is search on Google, like causes of toe rash or something, or skin rash, red color, pink, purple skin rash on my knee. I'm gonna check that way. Or wherever, or maybe go to Up to Date or something like that. So it's just a human nature that we will do it, and I acknowledge that. But I tell my patients that don't act on what you see over there. Verify that information from a reliable source. Talk to your doctor, and obviously PHA forum. You guys talk to each other, chat with them, and hey, what your doctor said, or ask on public forums and something like that, and get the right information.
Dr.
I
Patil
would
wants to
like,
comment here. Yeah.
yeah, I would like to add one thing. The problem is we are not accepting that we have this disease, which is affecting, because we tend to push ourselves. Living life, we are always in the guilt that we were doing this. We used to walk so much, we used to roam around so much, we were so adventurous, and now we are not able to do it. But if we accept that thing and we start slowing ourselves a bit, it would help us, rather than being in a state of mind that no, I need to push myself.
So, Dr. Patil, you very rightly pointed out, and when I was saying about the cultural thing, that's pretty much what I was trying to say, that it's a cultural thing, that you in India, if anything, first of all, and I'm going to be, may sound a little harsh, but I know my people very well. So there is a tendency to blame on something, like, if something bad happens, you don't have to blame on someone. Find me one person who doesn't have a disease. Find me one person who is never gonna take a tablet for anything in his life, his or her life. Find me you don't get worried about diabetes. I think that's a much bigger killer right now in India than anything else, but you get worried about PAH. The point I'm trying to say that yes, there are diseases also which you don't in day-to-day life pay much importance or worry. Oh, I got diabetes. I'm not gonna take tea with sugar now, so I'm just gonna go with tea without sugar. But diabetes has much more implication. It can affect your whole body organ. It can cause you to have a heart attack in one day, and then you die. And you majority of people, if they're not exercising and they don't realize this whole thing is about lifestyle and cultural change. I mean, it's difficult. We don't have to put blame on anything. Diseases are part of life. They are part of life, and we have to acknowledge it. I mean, whether you are going to be at loss if you are not acknowledging this. I mean, it happens in everyone's life. Everyone's life has different struggle. We all get diseases. You think that I'm sitting here looking pretty good, fresh in morning. I don't have anything. No, I do. I do. Everyone does. Everyone does. And that's just what life is all about. You have to accept. You have to move on, and that's it. I mean, that's my simple message to all of you, whoever is listening, wherever.
Um, Before we close, doctors, just two last questions, two very important questions. One question is
Yeah.
on air travel and how do cabin pressures impact us? And are there any threshold pH pressures for which, you decide that, no, I cannot do air travel anymore?
So if you are suddenly on supplemental oxygen, I generally tell patients to carry their oxygen and use it during the flight. If they are not on oxygen, um, I mean, there is a simulation test we can do, but just sort of a rule of thumb I use, if their oxygen on a walk test doesn't go below 95, they should be okay for a long shot. I mean, so for a short flight. But if their saturation goes below that on walk test, I recommend them to carry the oxygen with them.
Okay. Uh,
That's just, but ideally you should be doing a simulation test. So talk to your doctor before you book your
okay.
flight tickets.
Okay. Dr. Bobhate, anything to add here?
No, pretty much what Dr.
Okay.
Sahay said. Yeah.
Okay. And have you, Dr. Bobhate, been giving any, letters for Indian airport authorities or airlines for PH patients? Have you done that?
So if they are carrying oxygen, if they are requiring oxygen, then yes.
Okay. Then you need a certificate
then
from
you
you.
need a certificate. Yeah. If they don't require oxygen, then you don't require a certificate.
Okay. All right. Okay. And one last question is on vaccines. And I would actually ask Dr. Bobhate to speak here first because it's in the Indian context. Indian PH patients, have they taken vaccines and how is their response?
So the vaccines available in India currently are, as you know, the Oxford vaccine, that is the AstraZeneca, that is Covishield, and the Bharat Biotech, which is Covaxin. As of now, both these vaccines have been given only to medical professionals.
Okay.
And frontline health workers.
Okay, so obviously no patients experienced it yet. Although we have had 2 patients in the group who have taken it, and so far the last we heard was they are fine. The first couple of days were difficult for one of them. Dr. Sahay, how about there in the US? Because we see on Facebook groups that a lot of patients do report having taken it.
Yeah, I got my 2 doses of Pfizer. It was fine, nothing.
Okay. What about the PH patients, doctor? Those who've taken vaccines?
They all have done fine, nothing. I mean, I have not seen any single bad outcome in terms of a significant morbidity or mortality because of the vaccine.
Okay.
I mean, remember there were 75,000 cumulative patients in different trials, and there is zero mortality with the vaccine. And the COVID mortality, you all are aware, so you can see the risk and benefit there.
So do you both recommend that PH patients should go ahead and take the vaccines, the local vaccines available?
Yes. Whenever it's available in India, you should take it. Yeah.
Okay. All right. That's about it from me. Dr. Patil, over to you. Dr. Patil?
I'm sorry, I was muted.
Okay.
So thank you very much, Dr. Sahay and Dr. Bobhate, for joining us live today. You've cleared so many doubts and provided us with so many insights, which will be helpful for each and everyone present who has attended. And on behalf of PHI, I want to thank you for your thoughtful interest in our PHI patients and your unconditional offer to help us raise awareness and provide clinical help whenever necessary. I also wish to want to thank each and every fighter for joining today and making this event a hit. In the end, also I would like to thank our support team of Balaji Prasad, Roshni Chaudhary and Nitya Gupta. And with this, I would like to conclude this session.
Thank you, everyone.
Thank you
Thank
so
you,
much.
doctors.
Stay
Thank you.
safe.
Thank you.